And then we'll get this shared. All right, everybody's good on seeing the PowerPoint, like always?
Yep.
Perfect. I have to say, I felt like I was jobless for almost like a month of not lecturing. It kind of felt a little odd for me, to be honest. I told my wife when I finally had to go back into the office Monday, I was like, it doesn't even feel like it felt like I was retired for a month. It was it was an odd feeling. You'd think it'd be fun, but I felt kind of useless, to be honest. So chapter 16, respiratory emergencies. I truly do like this book compared to the books we've used in the previous year, because this book goes a little bit more in depth on stuff that I think it should, and it kind of gets rid of some of the fluff that I really don't think it needs to be adding in. It kind of gives you some of the down and dirty stuff, and when we get to some certain conditions or certain respiratory disorders, if there's some things that pop out, such as, you know, you're going to have a fever with this, or you're going to, you know, a seal-like barking cough with croup, that's textbook stuff that they like to hit on you with the National Registry. You know, they'll throw one word in there that's supposed to correlate to a condition, and your job is to recognize what they're throwing at you. So when those slides come up, if I think it's pertinent, again, I'm going to say, hey, you might want to write this down. You might want to try to memorize that, whatever it might be, because those are, again, telltale signs of that condition. And in regards to cardiology or respiratory, we're going to cover so much of this in a pretty short amount of time. So again, if you have questions, don't be afraid to ask. I'd rather you ask than just kind of stay in the background, not say anything. When it comes to calls that we are potentially going to see with respiratory emergencies, it's going to make up a massive amount of them. You know, I think they said is the second leading cause of people calling 911. I'd venture to say it's probably closer to the top when you think of all the things that somebody can have related to a respiratory disorder, not just you know, shortness of breath, not just COPD, but allergic reactions as well can come out as respiratory pains when you think about it. Asthma, it seems like everybody has asthma. It seems like everybody has a condition in which they have some sort of bronchospasm, especially at a younger age. A lot of people will grow out of it, but some people don't. I had really bad asthma as a kid, so I can speak on asthma pretty well, just knowing the conditions and the things how it felt, the treatments that we had to go through. We're going to spend a little bit of time on pneumonia. Pneumonia is something that usually accompanies some sort of bacteria, some sort of infection, whatever it might be, and it's really just kind of harbored in the lungs, and that's really what starts to get patients down. You know, if you hear of patients that have like bronchitis with pneumonia on top of it, or COPD with pneumonia on top of it, it's not the COPD that's essentially hurting them. People can live with COPD their whole life. It's the pneumonia that's really taking a toll on their lungs and taking a toll on their respiratory status. And like everything else, some disorders are genetic. Some might be from an external factor. You know, if somebody works in a tire factory their whole life, they're exposed to those fumes their whole life, yeah, they're probably going to develop something. So a lot of it can be modifiable, whereas some of it isn't going to be modifiable. Just kind of a review of the respiratory system. You know, it really, they kind of say it best here. It's an upside down tree. It very much is. If you think of our trachea extending from our neck, our windpipe, down into our lungs, branches off into these different portions called our bronchi. And then at the end of those, we have what's called our alveoli, our little grape clusters, right? And their job is to literally open and close continuously. They exchange carbon dioxide and oxygen. That's their sole job. Problem is they can be damaged very easily by something as simple as a cough, by something as simple as a hard sneeze. You can see alveoli collapse, which is fine because our bodies, when they're healthy, will regenerate things. It's when our bodies aren't healthy, we start to fight infections that these cells might not reproduce. And then we're kind of left with a body that's functioning at a little less than 100%. Anytime you see the word tracheobronchial, they're referring to from the beginning of our airway, from right below our glottic opening, all the way down to our lungs. They're referring to that whole section where air is going to travel when it first enters the mouth, down to our glottic opening, down to our lungs, where we're going to see that respiration. So anytime you see tracheobronchial, that's what they're referring to, from the trachea down to your bronchi. Does anybody remember what that point is where the lungs split in that picture, where we go from the windpipe to the right and left lung?
Rhina.
Rhina, absolutely. It's simple words like that that are pretty important to know, because that can make a big difference in terms of testing. If somebody doesn't know what carina means and that's the word they throw at you, that could be, you know, kind of detrimental to that question. In terms of gas exchange, carbon dioxide, oxygen, remember that there is a difference between ventilation and respiration. Respiration is really the gas exchange of carbon dioxide and oxygen, as opposed to ventilation, which is really the mechanical force of breathing. You know, when we're assisting somebody with a BVM, it's not for oxygen reasons, it's for ventilation reasons. It's because they don't have the mechanical capacity to bring air into their body. It might not be that their lungs aren't working correctly. It's just maybe they lack the muscle tone. Maybe, you know, they're unresponsive. They have been neurologically damaged. Maybe it's due to trauma. There's a bunch of different factors that could go into why somebody has ventilation versus respiration mismatch. Our alveoli, again, another review. Think of grape clusters. If I was to hold a bag of grapes up, right, that's a bunch of grapes in the bag. Each one of those grapes exchange carbon dioxide and oxygen. When they are submerged underwater, that's when we tend to get our crackles. Our alveoli are really what's making the sound when we are experiencing some sort of medical condition. Even wheezing, you know, wheezing is very much a lower airway disorder. It's almost lower airway swelling or lower airway constriction. That's why we're hearing, you know, almost like a whistle, but it's into the lungs, as opposed to a whistle up top would be more like a stridor sound due to some sort of occlusion or obstruction. Mediastinum, middle of the chest. I remember it by middle and sternum, to be honest. It's very much just the organs that perfuse our body and keep us breathing, if you could put it in layman's terms. It's our heart, it's our lungs, and it's the vessels that are connecting such. You know, it's our vital organs, if you will. It's not including our kidneys, it's not including our liver, or pancreas, or gallbladder. It's our heart, lungs, and the blood vessels, our great veins as well, that are really housed inside of our chest. And why we bring that up is because any one of those plays a role in our respiratory and ventilation system. You know, if we have a heart that's failing, we can have fluid back up in the lungs. We can have fluid back up into the body. If we have a blockage to the lungs, such as a pulmonary embolism, we could see the heart start to kind of go downhill, as well as a patient that doesn't have the ability to exchange carbon dioxide and oxygen. So those organs are vital, not just to the heart pumping, but also for the lungs being able to function. If the heart isn't pumping at capacity, you know, it's very much a car engine. If it's not doing its job, then the lungs aren't receiving the fuel they need to be able to keep functioning. Perfusion, active moving blood throughout our circulatory system, in addition to, again, supplying our lungs with essentially a gasoline, a fuel for them to be able to function. Not only are we supplying blood for it to exchange carbon dioxide and oxygen, but we're also supplying blood for fuel. You know, there's a couple things that we need for our body in regards to fuel. We need glucose and we need oxygen. Our bloodstream carries all of them. So if we have some sort of a blockage, like a pulmonary embolism that's blocking one of those arteries, the lung isn't getting fuel. It will last for so long, but then we start to see patients go downhill. And in patients that are potentially experiencing a PE, if you've never seen a patient that's had one, you can see a discoloration from like the nipple line up. I mean, they can be like cyanotic, they could be purplish in color, to be honest. They can have a normal O2 saturation and still feel like they're really short of breath. It's because, again, pulse ox takes a little while to catch up. Now, if you have those patients on end-tidal, you might be able to see some number changes. You might be able to see some waveform changes, to be honest. But just because their O2 saturation is normal doesn't mean that they're actually having the active respiration, doesn't mean they're getting that exchange. And that PE is a perfect example of that. When we get into cardiology, I know as providers now, you know how hand in hand the heart and the lungs go together. Our body very much has to have one for the other to function, right? Blood initially comes into the heart on the right side. So when our blood goes out to our body, it has to return, it comes back to the right side of the heart. From there, it goes over to the lungs back to the left side, and then back up to the body. Just a very much closed loop system. Now, the problem is if we have a patient that's experiencing, let's say, right-sided heart failure, the right side of the heart can't pump effectively. That's when we're going to start to see blood back up in the extremities. And we're going to start to see something called JVD, jugular vein distension. And there's a slide coming up on that as well, where the blood just can't get into the heart because the heart's not strong enough to pull it in. It's very much a vacuum system. Now, if the left side of the heart fails, we're going to see pulmonary edema. We're going to see fluid in the lungs because the heart can't pull that fluid out of the lungs. So it's got to reside somewhere. Generally, in adults, we can compensate for so long in a hypoxic state, especially patients with COPD. If you've ever heard, COPD patients rely off their hypoxic drive, which is very true. Some of them do. Their hypoxic drive is essentially once they live for so long in a hypoxic state that's somewhat mild, their body compensates by shifting some electrolytes around, and it tricks the body into believing that it has a normal pH. The problem with it is, if you've ever heard, we don't want to over-oxygenate COPD patients, is because if we do that, their body doesn't know what to do with that oxygen. It has no idea. It thinks it has a normal pH. So we introduce all this oxygen, then we start to skew their pH. And that's when the body essentially starts trying to fight itself and starts trying to change its respiratory rate and tries to get our kidneys to work overtime to get rid of a lot of that uric acid and that built up, what it thinks is as a level of acidosis. Kids are very much different when it comes to hypoxia. The number one cause of cardiac arrest in children is due to a respiratory problem. In our younger populations, it's generally due to hypoxia. If you have a child that has a really slow heart rate, I think 9 times out of 10, if we're looking at American Heart Association standards, they're saying it's related to some form of hypoxia. And that could be a kid with, tonsil issues, that could be a kid with croup, epiglottitis, any of those conditions, but kids can't compensate like us as adults. We can do it for so long. Kids just kind of go downhill really fast. People can live with heart failure. We've all seen them. People with CHF, that they have fluid in the lungs, they have fluid in their extremities. We can literally spot it if we're out in public. Just because we've been doing this for a little bit of time, we can see if somebody's extremities are swollen. People can live like that for a while. It can be maintained by medication, such as a water pill. The common forms of water pills you'll see, hydrochlorothiazide, also called HCTZ, furosemide, which is Lasix. What they do is they essentially pull extra water from the body. Therefore, it's going to lower blood pressure as well. Now, what you have to be careful of is that if we have a patient that's on a water pill and maybe on a blood pressure pill as well, are they supposed to be on both of them? As an EMT, when you're going through the medication list with the patient, you might not understand what all these medications do. You might understand a good portion of them because you're so used to them. You're so used to patients saying them. But as a paramedic, you've got to start to question things a little bit. Why are you on 2 different medications for blood pressure? Why are you on a water pill and a beta blocker, let's say, to lower your blood pressure? Those are things we can ask the patients. They should know, especially if this is a chronic condition. Or is it that they were supposed to, stop taking one of the medications and they had a stockpile of them and were feeling a little swollen today, so they decided they were going to double up? Just some things that we can really start to ask, especially during our assessments. When it comes to having to pull air into our body, remember, we rely off our diaphragm. It's just this really big, think of a block of muscles, right? Its job is when we need to breathe in, the diaphragm lowers, pulls air in based off of negative pressure. When it's time for us to exhale, that diaphragm raises. It's going to push all the air out of our lungs. I mean, even if you're sitting watching this right now, if you take a big deep breath, your diaphragm lowers. You go to blow all that air out, your diaphragm raises because it's pushing everything out. This is kind of, I hate to keep bringing up stuff from last semester, but just remember that our kidneys, our renal system plays a very big role in conjunction with our respiratory system. If we have a patient that has a skewed pH balance, normal is 7.35, 7.45, our body tries to compensate for it. We can see patients hypoventilate, slow their breathing, or we can see them hyperventilate. And that's just the body's natural reaction. Kussmaul respirations, they have fruity breath because they have this buildup of ketones and their body's trying to blow off that excess. If the respiratory system isn't cutting it, our kidneys then kick in and they say, you know what, I've got to work overtime. I've got to do a lot of filtering. I've got to get rid of some of this uric acid. I've got to make us less acidic. So our kidneys also somewhat go hand in hand with our lungs and our respiratory system. If somebody is breathing less than normal, remember hypoventilation isn't apnea or anything like that. Hypoventilation is decreased breathing. It's the mechanical process of breathing. It's not respiration. So when we see patients that are hypoventilating, some of the common reasons we could potentially see it in patients that have low blood sugar, they're unresponsive. We could see it in our opioid overdoses. We can see it in trauma, severe respiratory patients that are in respiratory arrest or failure trending arrest, patients that are in shock. We can see hypoventilation. But remember that as the patient slows their breathing, we're going to see a rise in carbon dioxide. And what does that do is it lowers our pH. If carbon dioxide goes up, our pH goes down. If carbon dioxide goes down, our pH goes up. It's very much an opposite effect. If we have a patient in cardiac arrest, a lot of times, depending on your protocols, they might say, if it's a prolonged downtime or a prolonged arrest, we can consider sodium bicarb. And that's just because we're assuming this patient is very acidic because they haven't been breathing for a while. So we give bicarb to try to fight that level of acidosis, to try to bring that pH down just a little bit in hopes that maybe we can get the patient back within normal limits to get a pulse back. Some of the other reasons we could see hypoventilation, the term atelectasis, I would probably know that top bullet point is collapse alveoli, when those little grape clusters just aren't functioning anymore. Once they stay collapsed for so long, they'll essentially die off. And our hope is that they regenerate, but if not, that's when we could see impaired lung function. Pneumonia, an infection in the lungs, fluid within the lungs, because we can't get that respiration. We can't get that exchange of carbon dioxide and oxygen. Asthma, which is bronchospasming of lower airway, and patients that have COPD, that live with emphysema, that live with bronchitis, chronic bronchitis their whole life. A problem with COPD is very much trapped air in the lungs. When we have those patients that have had some sort of a respiratory condition for a long period of time, they end up having that trapped air. And that's why when we talk about like emphysema or bronchitis, there's certain things you can look for with them. Emphysema, you might hear that they potentially have a barrel chest. That's because it's taken their body a little bit more, they need a little more strength to breathe. So over time, they develop muscles in their chest. That's why they kind of get that barrel chest appearance to them. Flail chest trauma. Don't rule out pneumothorax, whether it be a spontaneous pneumo versus a tension pneumo. Tension pneumo is generally caused by trauma. It's air that's pushing the lung and not allowing it to function, versus a spontaneous that we can see if somebody coughs too hard. People that are more prone to spontaneous pneumos are generally kind of tall and lanky. Those are the people that we'll generally see a spontaneous pneumo in. Most of the time for us, we're not going to be treating those. We're just getting the patients to the hospital. They might be complaining of, some sharp chest pain or maybe slight difficulty breathing. It's the tension pneumos that scare us more than anything, because that can lead to a decreased blood pressure because there's an opening. A condition that's listed here, and I can't remember if I brought it up last semester or not, but it's one that I would write down and that I would do some homework on, is Guillain-Barré syndrome. That's another thing that the National Registry likes to hit big on. And Guillain-Barré syndrome is really progressive muscle weakness that leads to paralysis in some patients. The problem is, due to the paralysis, we see patients that have ineffective breathing. We see patients that their muscles aren't able to let them breathe. We see patients that just don't have the muscle tone to breathe. So I would write down that Guillain-Barré so that way you can look it up. And it happens out of nowhere. I mean, patients one day could be up, able to ambulate, up, able to walk, and then they have this syndrome, and then the next day it's progressed to the point that they can no longer walk. So it's kind of an odd disease. It's not very common, but it is something to look up. Ultimately, if we don't fix hypoventilation, if we don't fix the mechanical act of somebody breathing, what we're going to see is cardiac arrest, because the heart very much needs oxygen to function. It's a fuel, right? We have two fuels. It's something that we try to prevent, right? We don't want our patients to get to that state, but knowing how to treat that to prevent it is key. Just throwing oxygen at every patient isn't going to fix them. Sometimes that can make them worse. When we talk about intubation, when we talk about, do I have to take somebody's airway? Do I have to perform an RSI? That's a really tough decision, and one that, honestly, in my opinion, is the toughest to make with a patient, because you're taking away one of the big three, airway, breathing, circulation. You're not putting one of them in your hands, and you're taking away from that patient. But if that's what's needed to keep the patient alive because they are losing the ability to do it on their own, then that's what you have to do. But again, you have to determine that. It's based off of your assessment. There is no black and white when it comes to that. It's based off your protocols and what you feel as a provider. Now, on the other end of the spectrum, we have people that might be breathing a little bit too fast. Well, as they breathe a little bit too fast, we're going to see a pH rise because we're blowing off a whole lot of carbon dioxide. Now, some things that can trigger hyperventilation, the most common that we're going to see is people potentially having panic attacks. Now, when it comes to panic attacks, if you've ever heard somebody say, or if they have an anxiety attack or whatever, it feels like my arms and legs are tingling. It feels like my arms and legs are going numb. That's what's called carpal pedal spasms. And it's due to a decreased amount of carbon dioxide, because we've blown off too much. And now we're in a state of alkalosis. Our pH is skewed. So now, yeah, you're right. We are starting to feel some numbness. We are starting to feel some tingling. And the best treatment we can do for those patients is to calm them down. One thing that's really easy is just talk to them. By making them talk, you're going to make them stop blowing off so much. Just have a conversation with them. Try to figure out what's going on. Try to figure out if it is truly a panic attack or not. Don't stand above them. And I said this in day classes, I hate standing above patients. If they're sitting on the couch, I'll sit next to them. I like to be eye to eye with them, so I don't look like I'm above them. I look like I'm just asking them questions. It doesn't have to be, if you think it's a panic attack, it doesn't have to be pertinent to what's happening then. It can be something stupid just to make a conversation. I had a guy having a panic attack last night. He had a Dolphin shirt on. So I'm from Miami. I made a conversation about the Dolphins. Initially, he wanted to go to the hospital. By the time that we were at the end of our conversation, which I honestly went to nowhere, he had refused treatment. Because he said he was feeling a little better. Yeah, that's because we were seeing a change in his carbon dioxide. So just have a conversation with these patients. Calm down a little bit. Our treatment used to be rebreathe carbon dioxide in a brown paper bag because we were raising our carbon dioxide level then. We don't necessarily do that anymore. It's more coaching breathing, maybe applying some oxygen. And remember, oxygen is very much kind of has the placebo effect for some patients. It's not going to hurt them unless we're talking like a COPD, but it could benefit them because they're going to calm down a little bit because they feel like they're being treated. We don't have them rebreathe their own CO2 anymore. It was a thing we did. It was way before me. Some people will still have it pre-hospital or not pre-hospital that aren't in pre-hospital medicine or don't work as a medical professional might think that that's what they should still do. It's not something we do. There's no protocol that we have saying, hey, grab a brown paper bag, have them rebreathe their own air. We just don't do that anymore. If, let's say, somebody's having a panic attack that's worse or bad enough, absolutely, we can provide some sedation. And that's not saying snow them. I'm not saying, knock them completely out. It's just enough to calm them down. It's a benzo, if anybody has anxiety and takes a benzo at home, it's the same concept. We're just trying to calm their nerves a little bit. But if you're going to be giving a med like that, we're going to the hospital at that point. You could also see this in patients with excited delirium that are really worked up. You might have to, provide them some sedation. Now, am I going to say what a certain dose is? No, because it depends on protocols and what medication, but you're going to see commonly like Valium, Ativan, and Versed are going to be the most common three. When we talk about a little bit heavier sedation, maybe you could throw in ketamine, but it's pretty much going to be your three benzos, Valium, Ativan, and Versed. The thing that we suck at the most as pre-hospital providers is listening to lungs. And it's not our, I don't want to say it's not our fault, but it isn't. We're in a very noisy environment generally. In the back of an ambulance or in somebody's house where our partners are continually talking, we generally can't get a good listen to what's going on inside the patient's lungs, or we're listening to the wrong spot. If we're going to listen to the lower part of the lungs, yeah, absolutely listen to the front of the chest. If you want to listen high up in the lungs, listen to the back. Listen right underneath the shoulder blades. That's a lot higher than the front of their chest. A good place to listen to is under their armpits. That's where we have the least amount of tissue. And also what's going to come into play is the size of the patient. If you have somebody that's 400 pounds, they're going to have a lot more tissue. It's going to be a little bit difficult for you to hear stuff. Now, one of the most terrifying sounds is nothing at all. When I can't hear anything and a patient's having trouble breathing, because that tells me that I don't have any air movement. Now, is that always the case? No, it could just be I'm not paying attention. When it comes to listening to lung sounds, I close my eyes and I try to distract myself or whatever it might be, because by closing my eyes, my body's focusing on the other senses that are available. So it's going to hone in on my sound. It's going to hone in on touch. Kind of the same reason that I was teaching you guys when you go to start an IV, feel for the vein. Don't look for it. Close your eyes, turn away, whatever it might be, because you're going to be able to, your sense of feel is heightened a little bit because you don't have that sense of sight at that moment. Just kind of small things that can make a difference. If you're providing a treatment to your patient, especially it's a respiratory patient, you should be listening to lung sounds every time you provide a treatment. You should be doing it every time you take vital signs, to be honest, especially if you think there's been a change in the patient's status. Try to listen early on with the patient. You have somebody that's having asthma, listen before you do anything else. Have your partner talk to him or whatever, grab your stethoscope, listen to it. The problem that I see a lot, and as a service director, is we use kind of subpar stethoscopes sometimes. We don't spend a lot of money on them, and that can make a difference as well. As opposed to buying a stethoscope that's maybe a little bit more expensive, but you're going to hear a whole lot clearer. Even during your clinicals, get in the habit of listening to lung sounds. Listen to heart sounds for all I care. Just listen. It doesn't matter what you're listening to. Just get in the habit of learning where to listen, what to listen to, and find what works best for you. Paroxysmal nocturnal dyspnea is really just somebody waking up with difficulty breathing in the middle of the night. And what they're saying is that could be a sign of left-sided heart failure. And the reason for that is because fluid starts to back up in the lungs because the patient is laying flat. That's why a lot of times with the respiratory patients, not just with that condition, but also a condition called orthopnea, where patients can't lay flat when they're sleeping because they have trouble breathing. And you'll see it a lot of times in heavier set patients. It's not uncommon to see, I wouldn't say that specific condition, but you're going to see patients that have a ton of pillows piled up because they almost need to sit up, or you're going to see patients that sleep in a recliner out in their living room just because they can't sleep while they're laying down or they have trouble breathing. What that means for us is that we might have a little bit difficult time with those patients if we have to backboard them or putting them on the cot. Make sure you sit them up, don't lay them flat. When we say position of comfort, that's what we mean. If that means sitting them up a little bit higher than you like, then that's fine. Remember, patients that are having breathing problems like to sit as far forward as possible. As they're sitting forward, their lungs are expanding a whole lot more, as opposed to laying flat where they have all this pressure pushing on their chest, and it's really limiting chest wall movement. Of course, when we talk about ABCs, our patients have to have a patent airway before we can move to the breathing step. Now, in regards to airway, We have total obstructions where we have patients that are choking and they have no air movement at all. We have partial obstructions. The number one cause of an upper airway obstruction in adults is their tongue. So what we're listening for then is that stridor, that really high pitched sound, almost like a whistle. And what that's indicating is that we do have some sort of narrowing of the airway, and that could even be due to an allergic reaction. What they're getting at when they talk about emphysema and bronchitis is what I kind of mentioned earlier. Generally, these patients are going to generally be a little bit heavier set, not always, but generally. And depending on how chronic their condition is or how severe, when you have patients with emphysema, that air that's trapped, so it takes a lot more muscle to move air in and out, you're going to start to see that barrel chest appearance. And that is, again, textbook National Registry, barrel chest associated with emphysema. Sometimes you might hear the term pink puffers or blue bloaters when it refers to emphysemic or chronic bronchitis patients. If that doesn't sound familiar, write that down. A pink puffer and a blue bloater. It literally refers to those two conditions. Something to consider as well is that as you increase the patient's workload, you increase their heart rate, whatever it might be, you're asking for more, you're demanding more oxygen. The problem is, if they're having difficulty breathing, they probably can't supply more oxygen. So be careful that you're not, having these patients exert themselves a whole lot. Maybe you're not having them walk down a flight of stairs. Take a look at their heart rate, see what their heart's doing. Is it elevated? If their heart rate's elevated, then it's already demanding a whole lot of oxygen. So how do we calm those patients down? Maybe, talking to them. Maybe it's applying oxygen. Maybe it is using some sort of sedative. If we don't calm them down, that workload is going to increase. And also, if we become frantic with them, because again, some respiratory patients can be kind of scary, that's just going to make their anxiety go through the roof even more. So I tell everybody, just be confident in what you're doing. Stay calm the whole time. It is not our emergency. At the end of the day, we get to go back to our station. But for them, it's an emergency. Try to stay calm, keep your patient calm, because when you lose it, they're going to lose it as well. I kind of mentioned this already. Patients like tripoding, they like sitting forward. It mentions head bobbing is an ominous sign. You're going to see that in a lot younger patients, is when they're trying to breathe, their head kind of leans forward. And that's generally indicative that they're using a lot of their chest muscles to get a full ventilation or get a full respiration. What you'll also see in pediatric population is seesaw breathing, where you'll see like their stomach and their chest move asymmetrically, kind of like bobbing as well. You'll also see what's called intercostal retractions. And that's where the skin in between the ribs is getting sucked in, because again, they're having to really use a whole lot of energy to force themselves to breathe. If we said that in an adult, that's the point for me personally that, okay, do I put this patient on CPAP to try and turn them around? If that's not working, maybe I am looking at intubating this patient. Now, depending on certain conditions that patients can have, maybe it could be, a condition with their alveoli. Maybe it could be even a muscle neurologic condition, traumatic damage to the thorax or the chest. You could potentially see these different breathing alterations. Think of somebody that has a collapsed lung. Sometimes we'll say asymmetrical chest movement, or what's called a paradoxical movement. Maybe they have a flail segment that one side of the chest rises, one kind of goes down because it's getting sucked in with each breath. Just some things to pay attention to as well. This is what I was talking about, kids using their accessory muscles. Another example of an accessory muscle is people, if you start to see their neck muscles flex when they're breathing, they're again trying to pull a whole lot of air and they're exerting a whole lot of energy to get a breath in. If you ever see in the parentheses there that IE, what that's referring to is inspiration slash expiration. And our concern sometimes is when we get an IE mismatch or inspiration expiration mismatch. And we can see that a lot in our emphysemic patients. Somebody say something. Somebody have a question? Gotta hurt somebody. We can see that a lot in our emphysemic patients. I want you to picture this. Patient with emphysema, they're going to breathe in normally. if you've ever seen somebody that has emphysema or a form of COPD, when they go to exhale, they kind of purse their lips together, almost like they're going to whistle, and they're creating back pressure. That's an example of an IE mismatch because they're breathing in normally, but their exhalation is not the same. Maybe they're not letting out the same amount of air. They're not letting it out with the same amount of force. I can tell you that. So that would be an indicative of a IE mismatch. Or, if somebody is taking 2 inspirations for every 1 breath, that's another example of an inspiration expiration mismatch. Different lung sounds that we're going to hear, crackles is really common, especially with our CHF patients where they have fluid buildup. Asthmatics, we're going to hear wheezes. Our concern is when you walk through the threshold of their door, if you can hear that without listening to lung sounds, it's a pretty grave condition. If you don't hear anything in the lower lobes of the lungs, if you listen to the front, you don't hear anything, listen to the back. Just because you don't hear anything in the lower lobes doesn't mean there's no air movement at all. If it could be that the lower lobes are so constricted that you're not going to hear anything. There is no air movement down there. So listen to more than just one spot before you fully say what's going on. And maybe that's listening, left low, left high, right low, right high. Be systematic about it and do it with every patient because that makes, muscle memory on how you're going to assess a patient. Kind of like you'll get really good at starting IVs and you'll start IVs the exact same way for the rest of your career. Do the same thing with lung sounds. Assess them the exact same way every time because it's just one less thing we have to think about when we're assessing our patients. Sounds through fluid in regards to our CHF patients are very difficult to hear unless it's crackles. And remember, that's just our alveoli trying to pop open underwater. Now, if somebody's wet sound or lung sounds are super wet, you can also hear it without even really listening with the stethoscope. It almost sounds like they're gurgling. The more fluid they have in their lungs, the louder that's going to be. Now, if you listen to it with a stethoscope, you might not hear it that clear, but if you hear it when you walk across the room, that's one that I'm just, okay, let's assess some vital signs because this is probably a candidate for CPAP. And wet lung sounds don't just mean a CHF. They could also mean patient has potentially pneumonia. Pneumonia causes fluid buildup in the lungs as well due to infection. It could be due to an injury within their lungs. So it's not always CHF. There are some other conditions in which we could see or hear lung sounds that are abnormal. If you ever hear the term adventitious breath sounds, that's one breath sound on top of another, one abnormal sound on top of another. So this could be, you hear crackles within a patient, but you also hear slight wheezing. So 2 different sounds, but they're heard on top of each other instead of, just continuous wheezes or continuous crackles. This is a combination of two sounds. I, for the longest time, did not know the difference between rales and rhonchi. Easy way to remember is rhonchi is more of a rattling sound. If anybody's ever heard the term death rattle, that's technically referring to rhonchi. It's really just phlegm and thicker mucus that is built up in the bottom of the lungs, and you're hearing that kind of rattle around, as opposed to rales, which is just normal crackles indicating fluid. So rhonchi is going to be more for mucus, as the word rales is going to be more for fluid. Stridor, upper airway closure. Again, it could be due to foreign body. It could be due to, in our pediatric populations, epiglottitis, upper airway swelling. It could be due to a tongue in adults. The times that I've seen stridor or heard, even snoring respirations, was generally because of the tongue. And first step is to make sure we have an airway that's patent. Don't forget BLS and jump straight to ALS. It could be something as simple as, let's drop an OPA, let's drop an NPA, and see if we get a change in airway status. There's that gurgling that I was talking about. Again, if you hear that, it's really indicative that patient has either potentially aspirated something, or they have that much fluid in their lungs, or there's also the possibility that it could be a CHF patient that's going into what we call flash edema, which is almost like a pink foam, which we call sputum, that can essentially come out of their mouth as well. if it's that severe. The times that you're going to see quiet breathing, what they're referring to quiet breathing is where you can barely hear any sounds when you listen with a stethoscope, is if somebody's breathing really fast, they're not going to be bringing in a whole lot of air into the lungs. So it's going to be very quiet for you to try to figure out what's going on. And shock. Remember, during shock, our body tries to lock things down. So during shock, our body is going to constrict all these blood vessels. It's going to limit how much our body is doing because it's trying to conserve energy at that time. So our body might go into like a low battery mode, if you will, to where it's doing enough just to survive. So it might be difficult to hear breath sounds on those patients as well. There's the sputum that I was talking about. It's I don't have a better way to put it than like a frothy foam almost. Pink in color generally indicates congestive heart failure because we're seeing that backing up from the lungs. Another one would be like a yellowish green brown. If you look farther down that list, a lot of times that indicates infection that's set in for a little bit of time. You'll see that a lot you could see it in pneumonia patients. You can see it in bronchitis patients that are coughing up a lot of phlegm. Another thing to think is if you have a patient that's coughing up blood, some questions that I like to know or I want answered at that time is have they had a fever associated with it? And I also want to know if there's a history of alcohol abuse, because somebody that's coughing up blood might not be respiratory related. It could be what's called esophageal varices due to chronic alcoholism and cirrhosis of the liver, hardening of the liver. And they develop almost like these blood-filled blisters in their esophagus, and they'll pop from time to time, and they, essentially vomit up blood. But anytime somebody's coughing up blood or anything like that, you need to start thinking, just to protect yourself infectious disease wise, is there a temperature associated with this? Start asking questions like, hey, have you traveled anywhere outside the US? Just simple things that we can ask that might protect us. And I know that we've worn a mask for I don't know how long on respiratory patients. It's not a bad thing until you for sure know what's going on with your patient. It protects you, and I wouldn't say if you're healthy that you're protecting them from something, but if there's a chance they have something, it's not going to hurt you to throw a mask on for your transport into the hospital. We can also see abnormal breathing patterns in neurologic injuries, traumas. We have somebody that gets in a car accident and hits their head on the windshield. Somebody in a diving accident, somebody dives into a pool that's a little shallow. They didn't realize how shallow it was. They hit their head. They have a compression injury down their spine. That's going to affect their breathing pattern. Now, two of these are big ones that National Registry likes to hit on. And that's going to be that top one, which is Shine-Stokes breathing, which is generally a period of like very fast breathing tachypnea associated with a period of apnea where the patient just stops breathing. And then they'll go back to breathing really fast and then they'll stop breathing. That's indicative of brain injury. The other one I'd like to hit at is Biot's respiration, which is the fourth one down on that list, which is really just sporadic breathing that doesn't make any sense. Patient can breathe deeply, can breathe shallow, fast, slow, all the above combined, and it just has no rhyme or rhythm to it. Generally, again, indicative of a traumatic brain injury or some sort of neurologic injury. If you think your patient is breathing too shallow and you can't coach them out of it, or it's a patient that's unresponsive, absolutely. Or if you think they're breathing too slow, absolutely. Assist their ventilations if they're still breathing. There's a difference between assisting a ventilation and providing a ventilation. Assisting, we're just matching the patient's breaths, but maybe we're speeding it up a little bit or providing more air to get down to the lungs, as opposed to somebody that's apneic and where you're now ventilating them entirely. We're not assisting them, we're providing the breaths. And I cannot say this enough, if your job is providing breaths, don't pay attention to what anybody else is doing. Your sole job should be making sure you're counting to 5, 6, whatever it is, and providing a breath. Making sure you're going to EC chest rise. I know that sounds stupid and that sounds like, basic CPR class, but it's one of the things that we oftentimes forget, or one of the things that we oftentimes don't pay attention to. And you'll see it during a cardiac arrest. Somebody's paying attention to the person doing the IO or doing something else because they're bored just bagging them. and then they realize that 10-15 seconds has gone by and they haven't given a breath, and then they give a couple fast ones to try to play catch up. If that's your job, that's your job. Just pay attention to what you're doing at that point. Depending on the person, you might be able to assess based off of skin color. Are they cyanotic? Do they have like a blue hue to them? Are they cyanotic around their lips, their fingertips? In kids, bottom of the feet is a really good indicator of cyanosis. You'll also see it around the mouth in kids. Another thing that's really big to assess in kids and not so much into adults is cap refill. Cap refill is huge in determining circulation in kids. Cap refill greater than 2 seconds, there's a potential they're dehydrated. Now, even in dehydrated patients, severely dehydrated can also play a role in the respiratory system, because that fluid is needed between the linings of the lungs. If we don't have that fluid in there, then the linings of the lungs rub together, and that's when we get what's called a pleural rub. So if we need to give our patients a little bit of fluid, great. Just be careful, because if this patient is prone to fluid backing up in their lungs, if you're giving a patient fluid that has respiratory problems, make sure you're assessing their lung sounds throughout the infusion so that no fluid is backing up in their lungs. Have them stick out their tongue. Does their tongue look dry? Simple stuff that we can easily do to determine if a patient is dehydrated or not. I'm not saying you have to memorize normal HGL levels or hemoglobin levels. I'm not saying you have to memorize any labs, but it wouldn't be a bad thing to know what normal hemoglobin levels are, because if somebody's hemoglobin is lower than normal, that means that we have a lower than normal potential for carrying oxygen. If somebody has a hemoglobin of 6, they're probably not carrying oxygen like they should. Our body, again, when our blood vessels go into shock, when we get cold, our body shunts blood away from our extremities. That's why we turn pale, because it's trying to keep as much as it can, as much circulation as it can into our core, into those vital organs that we talked about earlier. So that's when you'll see those patients start to become pale. You can also see that in patients that have a change in respiratory status. You'll see blood vessel changes as well, based off of carbon dioxide levels. There's our dehydration that I just talked about. Transport. I hate that it says usually transport to closest hospital. It should say transported to closest or to closest appropriate hospital, in my opinion. Depending on what's going on with your patient, you might be bypassing your level 4 or 3 hospital, taking an extra 20 minutes if you can keep the patient stable, and getting to the hospital that can really maintain this patient. And what I mean is not just respiratory patients. If I have a patient that's having a heart attack or having a STEMI, and I can get to a hospital that has a cath lab in 10 minutes, that's technically the closest appropriate facility, because the hospital that can take them to the little regional hospital level 3, level 4 might not have a cath lab, or doesn't have anybody there to have the cath lab running at a certain time of night. All we're going to do is kind of delay definitive care for that patient. Our assessment very much is based off of their chief complaint. Sample is great, and I use sample. Literally, if I'm doing an assessment, I'll write it down on a piece of paper, because those are the pertinent things I'm asking, but I don't ask them in that order, and I base it off of what the patient's complaining of. If they're complaining of shortness of breath, but they have COPD, the very first question I'm going to ask is, okay, you normally have shortness of breath. What changed to make you call 911? What changed in the last hour or whatever it might be to make you call 911? What prompted this? Because that's telling me a little bit more than the dyspnea. That's telling me a little bit more than difficulty breathing. Maybe they do say, well, I've got a fever now. Okay, then it's more than just a respiratory problem at this point. Maybe it is an infection of some sort. But I base my questions off of what the patient says. When they talk about, I'm having trouble breathing, the first question I'm asking is probably not, what's the last thing you ate? Unless I'm suspecting some type of allergic reaction, right? So base your questions off of the patient's complaint. Some of the most common complaints you'll see, in my opinion, number one is dyspnea, is this difficulty breathing. I can't say I've ever had a patient call because they're coughing more than normal, but I guess they could. And again, I'd say that difficulty breathing and chest pain are going to be in probably the top two, if I'm not mistaken, besides like a lift assist. But chest pain doesn't always have to be something cardiac. Chest pain could also be a respiratory issue. If they've lived with a respiratory condition for a period of time, they probably know more about that condition than you do. They probably know more about respiratory conditions than you do. Use them as almost like an encyclopedia. Ask them questions about their condition. If they have a history of asthma, if you spot a nebulizer in their house, ask them, how many neb treatments you normally take? What's your normal oxygen, O2 saturation? Those are things that they might know. What makes your difficulty breathing worse? Are there certain seasons that make it worse? Here in Iowa, we kind of are at a disadvantage because you have changes of seasons. While it might be great to see, it's horrible for respiratory patients. When we go from cold to warm to hot, that's when we really start to see those difficulty breathing calls come out. More prone for like fall into winter time. A patient that's not oxygenating correctly could be an altered patient. So try to get the patients normal. If families around, neighbors or whatever, ask them, if you think the patient's acting strange, ask them, is this normal for the patient? Do they seem to be acting appropriately for you? Don't just use pulse ox. I don't know how many times I'll say that. Use end-tidal as well. Try to get what their carbon dioxide level is. There's a picture of that JVD that I was talking about. So due to right-sided heart failure, we have fluid backing up again into the body. Essentially, this would also be a patient you potentially see pedal edema, lower leg swelling. Something I want to note about that X-ray is what they're looking at. What they're looking at there is a tension pneumo, generally caused by some sort of trauma. So if you look at the picture on the left, it's got a collapsed lung due to an opening in the chest cavity that's allowing pressure to leak in and push down the lung. If you look at the X-ray on the right, the lung on the right, where you see more of the dark, is the normal lung. The one on the left is the lung that's collapsed. If you can see, let me see if I can outline it here. This tissue right here, this lump, this is the lung that's collapsed. This is dead space. This over here is a healthy lung. Literally, it's like the same shape as what you would expect a lung to be in the shape of. That is a lung that's collapsed on the left-hand side. Now, are we going to see X-rays often? No. Maybe you work in a place that does transfers. You might be able to see the patient's X-ray before you transfer them. Kudos. But it's not something we normally be looking at, but that's what it would look like on an X-ray in regards to a collapsed lung. Now, the problem with a tension pneumo, they bring up tracheal deviation. If you can see on this left picture here, so they have a collapsed lung, which would be the patient's right. That pressure is pushing the trachea in the opposite direction. You can see how it kind of curves down here. That's what we call tracheal deviation due to the pressure. The other problem with that is that pressure is going to push on these vessels right here, our great vessels on top of the heart, our aorta, our superior vena cava, and we're going to see a drop in blood pressure for our patients. It's the same reason when we put a patient on CPAP, we see a drop in blood pressure. It's because we're putting air pressure on those vessels themselves. All right, let's take a 6-minute break. At 7:06, we'll come back and keep plugging away. All right, we're gonna keep trucking along. We've got like 80 slides left to go through. So some of the slides get easier, so I won't be talking as much through each slide. If you have a patient with difficulty breathing, some of the things that they're saying you can consider. I've never heard of this until I went through this PowerPoint. When pressing on the patient's liver, if they're in a semi-Fowler's position, so kind of laying up a little bit at an angle, that you can cause the jugular vein to distend. You can see JVD if you do that. I don't know if that's entirely true. I've never heard that, to be honest. So it's something I'm gonna have to look up and shoot you guys information on. Now, one of the things I have seen done is feeling for vibrations in somebody's chest. What you're really feeling for is when you feel those vibrations, it could indicate mucus and kind of gunk that's built up in their lungs, and you'll feel it really rattle around. In terms of trauma, obviously if somebody hits their chest really hard on a steering wheel, we can see, lung collapse, we can see flail segments, and maybe it doesn't cause a direct lung injury, but if somebody breaks a rib or has an injury to their chest, they're not going to want to exhale or inhale as much because it's going to cause them pain. So you can actually see their respiratory status decrease just to try and cause less pain for themselves. Pedal edema should be nothing new to us. Right-sided heart failure, we're going to see the fluid back up in the extremities. Clubbing could be indicative of a patient that's, chronically hypoxic. Patients that deal with hypoxia for an extended period of time, you will start to see that clubbing. I've never seen one that severe, but I have seen, where you'll start to see the edge of their fingernails almost kind of round off towards their finger. And that's really kind of how it looks in the early stages. But patients that, chronic COPD, chronic emphysema, chronic bronchitis for extended periods of time, live with it their whole life, yeah, they can absolutely develop clubbing. You're going to see potential skin temperature changes. And that's important, especially when we're talking about pulse oximetry. You might not get a pulse ox reading if somebody's really cold. What do you have a pulse in all the extremities? That could indicate a problem in itself. Now, if you are checking a pulse in a extremity that has a lot of swelling, that has edema built up, you might not be able to feel it the best. In those instances, you might use a Doppler to see if you can hear it and see if you've got a pulse present in that extremity. If there's any vital sign I would tell you to pay more attention to, you already know I'm going to say it's end tidal. Now, things we can look for in terms of shock, right? If somebody is trending shock, we can see a heart rate that's elevated. We can see a blood pressure that's normal. Anytime we see, a normal tensive patient with a higher than normal heart rate, their heart rate is compensating and keeping that blood pressure normal. Now, our concern is that they're going to go so far into shock that blood pressure is going to start to drop and that their heart rate is going to start to drop because it can't keep up that rate for so long. Now, as that happens, we're going to also see respiratory status decline when that patient goes into shock. Some of the other reasons besides cold that we could see pulse oximetry changes, nail polish as well. Not a physical thing such as cold or nail polish, but if we have a patient that has decreased hemoglobin levels, we could see a change in pulse or oxygen saturation as well. It is a great vital sign to be able to use in conjunction with something such as end tidal. I'm not discrediting pulse ox by any means. We try to keep people in the 94 to 99 range. We never say 100 because we don't have anything to measure past 100%. We could absolutely give our patient more oxygen they need, but we try to keep them at 99% because that's a number that we know they're not at 100 yet. But so anytime if you ever see that on a question, 94 and 99 is what we try to keep them at. As EMTs, we're taught everybody gets oxygen. We try to maintain them at 100%. That's not entirely true, especially with COPD patients that normally sat mid 80s, low 80s, whatever it might be. I had a COPD patient that was at 69 a couple weeks ago. That's severe hypoxia, especially, and even with a COPD patient. I mean, we ended up putting her on CPAP, working through the whole respiratory protocol. That's terrifying. Pulse ox 69%. My jaw almost hit the floor, to be honest. Now, in terms of what's a normal saturation for patients, or what point do we start to see patients decline or start to kind of fall off, or start to go into potential shock? For a normal person, non-COPD, that 80% is a really not solid number, but around 80. As anything less than that, we're going to see that patient again start to go downhill pretty quickly. 80s I'm okay with, because I know I can get it up from there. If I get a patient that's in the 70s, that's when we're going to start seeing lethargic. We're going to start to maybe see blood pressure changes. We're going to see changes in heart rate, because the body's now trying to compensate because it's essentially starving for fuel. The amount of air that we can expel in a breath, peak expiratory flow. If you've ever taken, one of those tests to during your physical or whatever it might be, to determine if you have optimal lung capacity, what they're really looking for is to determine that you don't have any sort of bronchoconstriction or any sort of edema within inside of your lungs. Normal person should be able to exhale 350 to 700 liters a minute, and that's just with normal breathing. What they're saying is anything down the 150 range is inadequate and really indicates that your patient is in significant distress. We don't have a way to measure that. Some services, I don't know of any in Iowa, but I have seen them out of the state that do carry those. And they'll even attach to a cardiac monitor, and they can tell patients tidal volume and residual capacity to determine if they have a problem with their lungs or not. Generally, the only medications that I will assist a patient with, I don't assist, I use my own EpiPen. I don't use theirs because I know my equipment. I'd rather give them a neb treatment instead of an inhaler. Or if your service carries an inhaler, use yours. Most of the time, patients don't have a spacer on their inhaler, as to where ours do, meter dose inhalers, and I'll get to spacers here shortly. I don't let them, nitrile, we can use their own. I don't let them take any other meds besides that if we're going to the hospital. I'm not going to let them take their scheduled dose of lisinopril or their scheduled dose of metoprolol, just because I don't know what kind of reaction we're going to see, especially in a patient that is having some respiratory issues, or maybe it's a newly prescribed medication that's leading to those respiratory issues. If they insist on it, then yeah, I'm going to call the doctor and just make sure he's good with them taking it, because again, in the ambulance, I don't have water for them to swallow any sort of pills or anything like that. So just be careful on what meds the patient's able to take at that point, or follow your protocols in regards to it. Most of the time with respiratory patients, our care is going to be pretty much supportive until we get those patients that are really going downhill fast. Now, with all patients, and I'm not just saying respiratory, when you go through scenarios, when even your NREMT testing, IV O2 monitor, that should always be in your mind as a paramedic. Do I need an IV? Do they need O2? And should I put them on a cardiac monitor? Those are the big three when it comes to treatment. As far as position of comfort, don't put them in a position that's comfortable for you. Put them in the one that's comfortable for them, because otherwise they're not going to be happy the whole ride in. It's going to cause more issues, especially if you have a breathing problem patient. Don't lay them down. Sit them up if that's how they want to sit. Even if they want to lay down, explain to them why you don't want them to. And most of the time, if you lay the cot down, they'll try to sit up on their own because they know they're going to have trouble breathing at that point. As the patients work harder to breathe, this goes back to demand of oxygen. Muscles have to work, and muscles have to have oxygen to function. They have aerobic metabolism. Anytime we don't have that oxygen, we're in a state of anaerobic. The more we ask the patient to do, the more oxygen we're going to burn through. And we only have so much, especially in a patient suffering from some sort of respiratory problem. So we need to be kind of careful what we're asking our patients to do. Don't have them walk down the stairs to the cot. Don't have them do any sort of, strenuous exercise or whatever. Some other things that might help them. If they have on like a bunch of layers of clothing, take a couple of layers off. If they have any sort of, I don't know, a large purse or a bag or something like that, and they're on the cot and it's, kind of laying on or whatever, move all that stuff off them. It might be causing a state of almost claustrophobia, to where the patient kind of freaks out a little bit and thinks they're having difficulty breathing. So just be careful and cognizant of some of that stuff. If you need to apply supplemental O2, remember, think BLS before ALS. Don't over oxygenate your patients. A patient that's sitting at 93%, I'm not strapping them to a non-rebreather. Base your oxygen off your patient's needs. Nasal cannula at 2 to 4 liters for patients that are at 88, 89% is perfectly fine. Now, patients that maybe 84, 83, you put them on a non-rebreather, that's fine. But remember to titrate that down. When the patient starts feeling a little bit better, don't just keep them on that in case they continue to rise. I mean, if that's what's needed to maintain them, sure, but try to maintain the comfortable level of oxygen saturation for them. Just because your machine says 94 doesn't mean that's what's comfortable for the patient. If you get up to like 98 and they're fine with that, try to keep them at that 98. And again, sometimes in our patients having an anxiety attack, oxygen they might have a good oxygen saturation, but oxygen might give them more of a therapeutic effect than anything. If you have to use a bronchodilator, the one most commonly we're going to be familiar with is albuterol, because it has beta-2 effects. So it's going to open up our lungs. It's going to create a larger pathway for air to move in and out of. Just be careful in patients that have potentially fluid in their lungs, such as CHF patients or patients with pneumonia, because albuterol can open up the lungs to the point that fluid gets in spots it shouldn't be, or it can cause a condition what's known as flash edema, which the patient at that point will then have fluid backing up out of their trachea, and that's the point where we have to intubate our patient. Now, most of the time we're going to see what's called a duoneb. Now, a duoneb is 2.5 milligrams of albuterol and 0.5 milligrams of ipratropium bromide mixed together, or atrovent is what it's called. Now, most protocols will say for your initial treatment, administer a duoneb. So albuterol is going to open up the lungs. Ipratropium bromide is more of a drying agent, if you will. It's going to kind of solidify some secretions to where the patient may be able to cough them up a little bit easier. But for those patients that have like a rattle, that have like phlegm, generally ipratropium bromide isn't going to do anything. Protocols will also say dose them once with a duoneb. Anything after that, hit them with just a plain albuterol treatment. You shouldn't have to keep giving that drying agent, that ipratropium. Most of the time, if you are going to be giving a bronchodilator, I prefer to do what he's doing there, using what I call the peace pipe instead of the mask, because a mask tends to freak people out. They can get claustrophobic, right? As to where they control how much they're breathing. I'm not doing anything besides handing it to them if they're able to, hold it or in a right state of mind to be able to breathe it. You can also do blow by, especially if you have a younger population where maybe you're just taping the canister to a teddy bear you have in your ambulance, or you're giving it to mom so she can hold it near the kid's face. If it's a patient that has a nebulizer at home, they'll probably be fine with the mask. I just prefer this method here because the patient then feels like they're in control and it might calm them down a little bit more. Now, when it comes to how much oxygen to run through your neb treatment, this is saying 6. I've found the optimal is around 10 liters per minute. Anything more than that, 10 to 12, I'd say. Anything more, you're going to get too fine of a mist and it's not going to be doing its job. Anything less, you're going to get almost just like bubbling and not so much of an aerosol effect that you're looking for. Now, don't forget that you can also hook up a neb treatment to CPAP. So if you have a patient that you're putting on CPAP, you have that tea that comes in your package, hook them up, give them a neb treatment through CPAP. It's not going to hurt them at all. It's not going to affect them. It might benefit them, if anything. And this just talks about our blow by that I was just speaking of. Some other things that can be nebulized, one that you're going to commonly hear, racemic epi, for the treatment of croup in our younger population, which is really going to reduce any sort of inflammation and swelling in the upper airway. Croup is going to be, you have that seal barking cough. We're usually only giving racemic epi for croup. Maybe your protocols say something different. You can technically aerosol like lidocaine. We can't. I mean, I haven't seen a protocol for aerosol and lidocaine. Some steroids can be aerosoled as well. But it's not just albuterol that can be aerosol. There's a handful of different meds. Now, this is that spacer that I was talking about on the inhaler. So what that spacer does is it actually collects medication. So once you push the top of that inhaler down to disperse that med, that spacer collects the medication so that when the person goes to inhale, they're receiving it all at once, as opposed to just putting their mouth directly on the inhaler. They might stop inhaling before it's delivered all the medication. So that's kind of why we use those spacers in between there, because it's really going to get all the medication for that dose into the patient's lungs. This is kind of hard to explain. If anybody's never used an inhaler or ever helped anybody with an inhaler, honestly, just I always hold the bottom with my thumb, the top with my pointer finger, tell them to take a couple deep breaths before, and then I tell them, hey, at this, when you take this next big deep breath, inhale as deep as you can. And that's when I push the canister down when they're inhaling. And I have them keep going. I tell them, keep going, keep going, keep going. And then I have them hold their breath to allow that medication to get down to their lungs. Then they can slowly exhale. And that should be how you should administer or assist your patient at that point. The problem with inhalers is that they are pressurized canisters. Over time, if the patient hasn't been using it, it can lose pressure. A lot of times patients don't use them unless they need them. So they could be expired. So the medication is not really going to have its effect. It could be left in an environment where the medication probably isn't usable anymore. And then again, you have the instances where the can just has lost pressure. Steroids, one you guys probably hear is solumedrol. That's going to be the most common steroid that we give. It goes by the name of methylprednisolone. I always want to say methylprednisone, but anything that ends in zone or own is generally a steroid. Now, we're not going to see benefit of this with our patients, but it's really for our patients long-term once they're at the hospital, because we're giving a steroid to really reduce swelling, to reduce inflammation. Same why people get steroid shots in their back or steroid shots in their knee is really just to reduce inflammation. Your protocol is probably going to say, give a steroid. For every breather patient I ever get, I always give 125 of solumedrol, which is that methylprednisone, just because I've seen good effects from it. Especially if you're doing ER time, you'll see patients that have come in and EMS will drop them off, and the doctor will even talk about the steroids that were given. A lot of times they won't even repeat the steroid because EMS gave it. It's not going to hurt the patient. The biggest thing. Now, and I said this before, if you need to give your patient fluid, that's fine. Just be careful of lung sounds. Now, in the CHF patient that maybe has low blood pressure and also has crackles, it's kind of damned if you do, damned if you don't situation. Me personally, if they have low blood pressure, but they also potentially have crackles in their lungs, I'll give them fluid because I want them hemodynamically stable. And then I can put them on CPAP once I get a pressure that's good to get that fluid pushed away from their lungs. They bring up using nitrates. A lot of protocols will say prior to put somebody on CPAP, give them a spray of nitro, because nitro opens up blood vessels, right? Example I use today, if I have a balloon that's not blown up, it's, the walls of the balloon are thick. If I blow a balloon up as to maximum capacity, the balloon changes colors and the walls will get thin. That's what we're doing to the blood vessels when we give nitro, is we're expanding them. When we expand them, they get thin, things can pass through them a lot easier. Think of that balloon. As it gets bigger, it's no longer taking its color. A lot of them will turn clear and light can pass through them. So they become almost like a sponge at that point. We're doing that to the blood vessels so that when we put the patient on CPAP, we push the fluid back into the vessels. That's the reason that we try to give nitro to the patients that can sustain it. Now, the bad part is nitro drops blood pressure and CPAP drops blood pressure. So you need to make sure that your patient has adequate hemodynamic stability prior to doing both of these. Otherwise, you can see a patient go into shock. I wouldn't do it without any sort of IV access or fluid readily available, unless they've got some crazy high blood pressure, maybe, but you'd be pretty smart to get access afterwards pretty quickly, just in case the patient starts to go south. If you are giving fluid to the CHFers, I'd mentioned this, make sure that you're listening to lung sounds. Make sure you're not overloading with fluid. Make sure that fluid's going where it's supposed to be and it's not just backing up in their lungs. You generally won't see edema show up in their extremities in the short period of time that we're going to have them. But again, just make sure it's going where you want it to and into their blood vessels. Some services carry Lasix, some don't. A majority of them don't, I would say. Maybe for those services that have a little bit longer transport time. The only issue with that is if there's a potential the patient has to use a restroom because you're giving a diuretic, you're trying to remove water out of them. Through giving a diuretic, you're going to lower blood pressure as well, but you're also going to change electrolytes. You're going to get rid of sodium, you're going to get rid of potassium. So a concern with that is if they already have electrolyte levels that are skewed and we give a diuretic, we could see our patients go into some cardiac issues or cardiac arrhythmias just because of the electrolyte shifts. Now, another thing with Lasix is we always mention don't push it too fast because you can actually cause your patient to have ringing of the ears or even temporary or permanent deafness where they have hearing loss. And that's due to a fluid shift and fluid that builds up with inside the ear, like kind of like a swimmer's ear, to where they lose their sense of sound. So generally Lasix is a little bit slower push than normal. And if you push it too fast, I learned this yesterday, you can actually see cardiac arrhythmias in patients that you push Lasix a little bit too quick. Be careful if the patient has renal issues, like maybe a patient that has kidney cancer or kidney failure, is then you're asking the kidneys to do something that they're not capable of doing. So just be careful with what patients, if you have to give a diuretic. If you get the chance to give one in the ER, ask the nurse or the physician all about Lasix. It's kind of an interesting drug, not one we give very often, but it has its place. If for some reason, oxygen's not working, my neb treatments aren't working, you have to put your patient on CPAP, that's perfectly fine. I love CPAP, in my opinion. It's like my go-to before my patient has to get intubated. And most of my patients that I've had that I put on CPAP, it has changed and turned them around. Just be careful with CPAP because it is continuous pressure. So you can see that pressure spill over into their stomach if they're not breathing correctly or if they're inhaling too deeply. And that can cause vomiting due to like gastric upset. Now, in hospital, or even if your service carries a vent, you have the ability to put patients on BiPAP, which instead of continuous pressure, BiPAP utilizes two different pressures. So it might be one pressure for inhalation versus a different pressure for exhalation, trying to match what the patient's breathing is. But during inhalation, it's going to, force as much as it can into the lungs and then try to match the exhalation pressure of the patient. So in hospital, they'll usually throw the patient on BiPAP prior to intubating them if, they're trying to turn around without having to use an intubation technique on the patient. I truly love CPAP. If you get the opportunity to put people on CPAP, do it. It honestly, I can't say it enough, turns patients around. Not just for, when you say CPAP, some patients might not understand what it is. And that's a question I like to ask patients too, is have you ever been on CPAP before? Or, another question is, have you ever had to be intubated before? That'll tell you how severe their condition can get. Some patients, when you bring up CPAP, might think, it's what's used to help them sleep. Sure, it is. It's just that one's a lot lower pressure than what we are using when we're treating them medically. And again, be careful because you can see a drop in blood pressure due to increased pressure in the chest with CPAP. Patient has to be conscious, has to be have correct mental status. They can't be unresponsive. They have to be able to breathe on their own to receive CPAP. Okay, you can see how CPAP's kind of forcing the diaphragm up, forcing it down. BiPAP, again, two different pressures. One for inspiration, different pressure for exhalation. I always get ahead of myself and don't even think about it. Now, in the case that these are not working, CPAP's failing, maybe you tried BiPAP, BiPAP's failing. That's now the point where you need to determine, am I going to continue this just to get the patient to the hospital, or am I going to turn to intubating my patient? There's a difference between RSI and medication assisted. RSI is when we're using a paralytic, right? We're pre-medicating maybe with fentanyl, maybe we're using something such as ketamine or etomidate, and then we're using a paralytic to, get rid of that upper airway spasms, to get rid of their gag reflex at that point. If you pre-medicate them and use ketamine or etomidate, and the patient has no gag reflex at that time, and you decide to intubate them, that's not an RSI. That's a medication assisted airway. So know the difference. Medication assisted, there is no paralytic. RSI, there is a paralytic, is the big difference. My protocol basically says check if the patient has a gag reflex. If they do, then I use a paralytic. If they don't, great, I intubate them. Not all patients are going to require a paralytic. And honestly, I'd prefer not to use the paralytic if possible, just because if I can't get the tube and maybe I'm on a long transport, I'm the only one back there, I could see, kind of being up a certain creek without a paddle, just because I don't have the hands back there. I might need to help me manage this patient at this point, and they're being paralyzed. So it's going to take a little bit more to bag them. And what they're saying is check all your possible BLS before you go to intubate somebody. I can't imagine intubating a patient, getting to the hospital and them asking, what the patient's blood sugar was, and you didn't check a blood sugar and they were unresponsive, and a blood sugar is like 30. They were intubated for no reason. When something as simple as dextrose could have turned them around, or something as simple as Narcan could have pulled your patient out of a overdose, but you chose to intubate them instead. Now, there are the patients that you can use epi in. Epi is a great drug for difficulty breathing. Epi is going to work by opening up lungs. It has a beta-2 effect. It also has a alpha effect, so it's going to constrict blood vessels, and it's going to increase heart rate. Now, that might be a little bit of a concern to patients that already have an elevated heart rate, but you'll even notice in your difficulty breathing protocols that it says consider epinephrine. Now, epi 1:1, there's two different concentrations, right? There's epi 1:1, epi 1:10. Epi 1:1 is used for sub-Q and IM use, period. That's it. Epi 1:1 is not meant to be given IV unless it's diluted down. Epi 1:10 is your intravenous epi. That's what we use for cardiac arrest. That's what we use for, if you're going to give epi intravenously for an allergic reaction, we use epi 1:10. We don't use anything else through the IV, because 1:10 is very diluted as opposed to 1:1, which is more concentrated. That's why we give it sub-Q or IM. Personally, in the patients that I have to give it to that are having that bad trouble breathing, I do it prior to starting an IV, to be honest. I mean, think of an allergic reaction. I'm not spending so much time worrying about an IV when the patient's having that big of a time trouble breathing, when I can just give epi IM right away, such as an EpiPen. Dose is going to be the same as an EpiPen. Epi 1:1, 0.3 to 0.5 milligrams. If you're giving an IV with 1:10, it's the same, 0.3 to 0.5 milligrams. I mentioned already about the tongue. Most common sound, if there's an obstruction, most common two, I'd say, stridor, partial obstruction, or snoring, which we're going to hear most commonly with the tongue. Sure, you can hear gurgling if this is potentially some form of aspiration. Squeaking, you're going to hear more in our younger population, in addition to grunting. Those are really indicative of a patient, especially infants that are having severe difficulty breathing or a severe respiratory distress problem at that point. If you need to, I wouldn't even say, I keep on saying BLS before ALS, and I can't say that enough, because if you don't have to go very advanced on stuff, don't. And I say that as nicely as possible, but I get in the same mindset as well. I've had to be reminded by EMT partners of mine that, hey, maybe you should do this instead. And I'm like, oh, that's probably a good idea. I don't want to go, too advanced when something simple might fix my patient. So instead of, hey, I need to intubate this patient right away, can we get away with putting an OPA in or an NPA and bagging them until we can get them a little more stable? And I have a little bit more time to where I can prepare my stuff for intubation. So that way I'm not making any mistakes. Can manually displacing the airway, open it up? Can that give me a difference? Head tilt, chin lift, jaw thrust. Will that make a difference in my patient's sounds? It could, depending on what's going on with them. When it comes to infections that we're going to see with patients, common one is going to be croup. And again, that's in our younger populations, generally caused by an inflammation of our larynx, trachea, bronchi. So really all of our lower airway, kind of maybe extending a little bit into our upper airway where we get that swelling near the glottic opening. Big thing is that barking cough. I cannot say that enough for croup. That is, again, textbook National Registry that they like to throw at you. Hoarseness of voice, sure, but that could be even from like tonsillitis or a sore throat. Stridor, if Stridor's thrown at you, it's some sort of upper airway obstruction. Even, it could even be an allergic reaction. What they're saying here is that as the diameter of the tube decreases, resistance to flow increases. Okay, so blowing through a straw versus blowing through a garden hose. The straw has less diameter, so we're going to have more resistance. As opposed to a garden hose, greater diameter, less resistance. If anybody works, is in the fire service, I don't know which of you are. It's the same as friction loss, right? Larger the hose, more water's gonna get flown. Smaller the hose, the more pressure we're gonna have. It's very much the same. Blowing through a straw versus blowing through a garden hose. In our pediatric populations, their airways are a lot more floppy. They're not as formed as ours. So what that also means is that they can be occluded or obstructed a lot easier than us as adult airways. They don't have those cricoid rings that we do that kind of give our trachea structure. Most common type of infection we will see, tonsillitis, croup. There's not a whole lot we're going to do for these patients besides supportive care. We try to avoid any sort of manipulation or any sort of laryngoscopy just for, we're not trying to worsen it. We're not trying to create any trauma to the upper airway. The minimal amount you need to do to keep the patient stable is what you need to do. Don't go above and beyond just because you want to. Don't, put patient care in front of ego at that point. Patients that are aspirating, one that always comes to mind for me is patients that may have drank a little bit too much. And, I remember in high school, if we were out on a bender with our night buddies or something like that, sleep on your side, don't sleep on your back, because your concern was always that they were going to aspirate vomit. Other patients you get concerned about, tube fed patients. So some of our special POPs patients, patients that, geriatric older patients that have progressed dementia that might not be able to swallow appropriately. Patients that are unresponsive aren't going to be able to swallow either. These are patients that we're going to see aspiration with. And our concern with aspiration is that whatever that substance is, liquid, object, is going to get pulled down into their lung. And over time, that's going to lead to an infection of some sort. It actually is a high mortality rate when we have an aspiration. Now, our best thing that we can do for the patient, suction them if possible, if we can get as much of it out as possible, and monitor the patient's airway and get them to the hospital. They're probably going to need a scope or some sort of surgery, depending on what was aspirated to clear out their lungs. They're most of the time probably going to end up intubated at the hospital. If I'm not intubating them, they're going to probably be intubated at the hospital again. But if that's what you need to do, then that's what you need to do, especially if there's a concern for airway collapse or for an airway that you do not think is clear, and you need to either visualize and pull some stuff out with forceps and then intubate the patient. But I mean, really, again, it's keeping the patient stable, because the definitive care is what they need. They need more than just a paramedic in the back of the box. Jumping into our COPD, right? Our obstructive lower airway disorders. Most common ones that we are going to see is emphysema and bronchitis. What happens in these two is that our pulmonary structure is kind of changed over time, especially with these patients that have, chronic emphysema or chronic bronchitis. Sure, maybe our long-term smokers, if they quit smoking for a period of time, we can see some of that damage reversed. Asthma is technically a form of COPD in itself. And again, if it's a younger person, many times they grow out of it. But asthma does very much the same thing as emphysema and bronchitis, but asthma is more of an acute condition. We can reverse it pretty easily with albuterol, as opposed to our two other chronic conditions, which we really can't. What happens is our tubes, our bronchi, if you can see this right here where I'm drawing, kind of get pinched off down to our alveoli. Well, what happens is when that's pinched off, there is no gas exchange. So we get this gas trapped in the alveoli. And the patients have to breathe a whole lot harder to overcome that pinched area. That's those patients that get that barrel chest because they're using a whole lot of accessory muscles all the time just to breathe. Again, in our emphysemic patients, you might see that pursed lip breathing where they almost looks like they're going to whistle. They hold their lips really close together, especially on exhalation. You're going to see potentially an inspiration-expiration mismatch, maybe JVD, if there is a potential that they have, right-sided heart failure or their fluids can be backing up. Treatment for them is going to be pretty much the same, mostly supportive. Again, these are patients that have dealt with this a pretty long time. Follow your respiratory protocol. Maybe we're giving Solumedrol for a steroid. Maybe we're giving a neb treatment. Maybe we're giving a duo neb. If it's a COPD exacerbation and it's pretty severe, maybe we're throwing the patient on CPAP. It just depends on your assessment of the patient, what they need at the time, and their associated vital signs. Can they handle CPAP? Can they handle? Are they in the right mental status to be able to take CPAP? Asthma. In addition to hearing wheezes, remember to look at your waveform on your monitor. If you have, instead of a normal square when it comes to end tidal, such as this, with asthma, you're going to have like a shark fin. And what that's indicating is bronchospasms. That's indicating that we're having some sort of narrowing of the lower airway. Now, kids are going to have asthma. They're going to be the population that we are going to respond to the most when it comes to asthma. It's probably the most common respiratory condition that we see. Now, what we get concerned about is asthma associated with respiratory failure. Maybe they have an infection as well, or asthma that's left untreated. Another condition that scares us is status asthmaticus, which is a prolonged asthmatic attack that is not refractory to your treatment. Anything you throw at it is not going to fix it. Generally, patients with status asthmaticus, again, an asthma attack that's just not responding to a neb treatment, duo neb, albuterol, nothing, those patients end up intubated. And again, those are the patients to maybe ask if you think it's that severe. Hey, have you ever had to be intubated for this? I can think of a certain patient that I don't want to say a frequent flyer, but every time we went to her, we would have to intubate her just because she was having such a horrible asthma attack that we just knew if we went to that address for an asthma attack, we were going to end up intubating her and taking her to the hospital. That's just how severe it was. Nothing else we did worked for her. You can have bronchospasms randomly, and that's a concern for us when we're intubating patients. And sometimes they can be triggered by certain things like chemicals. They can be triggered by allergens. Allergies itself will cause bronchospasm. When we cough, we can bronchospasm. When we sneeze, we bronchospasm. It's just a rapid constriction of the airway. Okay, status asthmaticus, I talked about. Just talked about bronchospasms. Okay, there is a difference between narrowing of the airway due to bronchospasms and narrowing due to edema. Bronchospasming, again, is the muscles that are contracting, causing that airway to close. So it's, us essentially flexing. Edema is when we get that fluid that's pushing in on the airway, causing it to shut due to pressure. So bronchospasms, muscles, edema is fluid pushing it shut. I know that might sound stupid, but some people kind of get that confused. Bronchospasms, how do we treat it? We treat it easily. Neb treatments. We give them albuterol. Hopefully it works. And these are literally the treatments that I've been saying to you guys. Okay, so top one, bronchospasms, we can treat with Duoneb, ipratropium bromide, and albuterol, or just plain albuterol. Edema, okay, we're gonna give corticosteroids. There's our solumedrol. Mucus secretion, okay, some sort of drying agent, some mucolytic. This could be your ipratropium bromide that's going to dry up some secretions. It's not going to dry up mucus. It'll dry up fluid that's a little thinner, I would say. Like bits of phlegm, it's not going to do anything to. There is a kind of like a fine medium, I would say, almost like slime is what it's going to kind of harden up, if that makes sense. Water, it's not going to do anything to just plain fluid. But just be careful because you can see those patients again kind of go downhill, especially like with flash edema that I was talking about. Restrictive lung diseases caused by trauma. So this could be patients that have had some sort of car accident or had some sort of spinal injury or some sort of chest injury that really impairs their ability to move air. This could be a patient that's paralyzed from the nipple line down. It's their body just doesn't have the ability to make the muscles work to be able to breathe at that point. It's not so much a restrictive lung disease. I would say more of a disorder, if you will, that's causing that. Now, that Guillain-Barré is a perfect example of something that could limit your ability to move air. Just that progressive weakness that led to a paralysis. When it comes to bronchitis, most of the time these patients are heavy cigarette smokers, generally overweight. They're what we call blue bloaters. Just because they usually have like a bluish tone to them because they live in hypoxia. Normally have really high end-tidal readings with decreased oxygen readings. So these are patients sitting at 82% on oxygen with an end-tidal of 52. And they're kind of bluish in color. A lot of times they're coughing up. If you've ever, I have relatives that are chronic smokers and they're just coughing all the time. I used to be a smoker and I used to cough every morning horribly. That's kind of what bronchitis reminds me of. Kind of like that, I don't want to say wet cough, but almost phlegmy type cough where they're coughing up a lot of material. And again, can be reversed depending on, quit smoking, change some of the modifiable risk factors. Some of it does come with genes and genetics, but emphysema, barrel chested, because the muscles around their chest have grown to allow them to pull air in. We repeat the same movement over and over. We have to grow muscle there at that point. Emphysemic patients are what we call pink puffers. They're usually kind of reddish, pinkish in color. Emphysemic patients also breathe a little bit faster. I'm not saying they have adequate volume, but their rate is faster because they're trying to compensate for the volume loss based off of rate. Whether it be an emphysemic patient or a patient with chronic bronchitis, you have the potential to hear very much similar sounds. You're going to potentially hear wheezing. You're going to potentially hear rhonchi, that rattling from like mucus. Our care with them is supportive. Treat what the patient is complaining of, not what you think is going on with the patient. If they're complaining of being short of breath and you put them on oxygen and they feel a whole lot better, leave it at that. Give them, solumedrol. Sure, start an IV on. Give them solumedrol. Don't throw them on CPAP if they don't need it. Treat them with what is going to treat them and benefit the patient, not what benefits you or your ego. A fear is patients that develop pneumonia. A good telltale sign that somebody has pneumonia is, again, that brownish, greenish stuff that they're kind of coughing up in the presence of a fever. If somebody has a respiratory issue associated with a fever, as an EMT, we start to think, okay, maybe you got the flu, you got a common cold. As a paramedic, we've got to kind of change our thinking. We have to look at a little bit more assessment findings. Do we have them coughing up something? What are our breath sounds? Do we hear potential for fluid in their lungs? And just because it's an infection, we could also see or hear a pleural rub, almost like sandpaper gritting back and forth, because they've lost that layer of fluid between the pleural linings. Fever, I think of two things. I think of pneumonia and I think of tuberculosis. Pneumonia is actually really terrifying, especially with a patient that has prior respiratory disorders, because pneumonia is an infection that their body might not be able to fight. Right-sided heart failure, peripheral edema, we're going to see that JVD. Those patients are probably going to end up on a diuretic of some sort, as opposed to left-sided heart failure. We're going to see that back up in their lungs again. It keeps repeating it for a reason. You need to know right-sided backs up in the body, left-sided backs up in the lungs. And it's not due to a problem with the body or the lungs. It's due to a problem with the heart. It just can't pump as efficiently as it should. The patients that I've had, honestly, that crump the fastest are the ones that are having exacerbation of COPD. They just, they live with whatever it is, bronchitis, emphysema, for so long, and then something triggers an exacerbation, and they just like decompensate fast. I mean, pulse ox starts dropping. They are struggling to breathe at that point. And, you're throwing medications at them. It's not doing anything. The patients that I've had, CPAP benefits them more than anything. And the bad part is I've even asked some of the patients, have you had to be intubated before? And they say no. And I say, if it gets to that point, I might have to use a breathing tube and if they say no, I'm kind of in a bad situation there, because even if that patient goes unresponsive, I can't really intubate them because their wishes were to not be intubated. I can't go off implied consent at that point because they told me no. And a specific patient we brought to the hospital and told them that they ended up putting the patient on BiPAP just to see if that changed it. I mean, I told the doctor, and the doctor was like, yeah, I guess we can't really do it either. So just something to think about. And end stage chronic COPD, these patients are probably going to end up on a ventilator if they're not already. They just don't have the lung function to support oxygenation. They don't have the ability to ventilate. These patients, unfortunately, if they're not intubated and you have to intubate them, they're probably not coming off a tube until the end of their life. At that point, they're probably not coming off a vent. Their lungs have essentially shut down at this point. They just don't have the alveolar capacity. Their alveoli have died off. They haven't regenerated. We're essentially keeping them alive as best we can. But most of the time, when they're intubated on a vent, it's really the end of life at that point. It's just enough for them to be able to, say goodbye to family, talk the last wishes, that sort of thing. It's just to keep them alive for a very short period of time. It's not a long-term solution. One thing to watch out for, and not just when it mentions trauma, this is also trauma that we could cause to the airway through trying to intubate these patients. With trauma and blood loss, as patients lose blood, we're going to see a loss of hemoglobin. As we see a loss of hemoglobin, we're going to see the ability to carry oxygen decrease as well. So with these patients, it might sound stupid, stopping their bleeding might be key to fixing the respiration status as well, because their body's trying to compensate. And I'm not saying that's going to happen quickly, but the more that patients bleed out, the more that it's going to affect their respiration status as well. They're going to see a pulse ox that just can't compensate because they have a loss of hemoglobin. I mentioned that some patients rely off their hypoxic drive. I'll give you guys a break in like 5 minutes, and then we only have like 20 slides left. I know I've been talking a long time. I apologize. Hypoxic drive is patients that live in hypoxia, and they've done it for a long period of time. Their body now tricks itself into believing that they have a normal pH. Problem is, you administer oxygen to these patients or over-oxygenate them, and you can actually hurt them because their body doesn't know what to do with that. It thinks everything's normal. And you're going to see this really in your chronic COPD patients that have lived with COPD for an extended period of time. You can't tell who's relying off their hypoxic drive, unfortunately. You can't say this person's relying off hypoxic drive, this person's running off their normal drive. You can't say that. We can't say that as providers. So it's kind of hit and miss, unfortunately. But just know you can see patients worsen from putting them on oxygen. Actually, you know what? I'll give you guys a break now. I'm going to give you guys 10 minutes, 8:06, come back, and literally we have like 25 slides to go through, and then I'll answer any questions for you guys. So take 10 minutes and we'll come back here and finish this up.
I have a door. Will I have a seat? Just have a seat, man.
All right, guys, let's wrap this up. We left off talking about hypoxic drive, how, some COPD patients live in hypoxia, so their body kind of tricks itself. Over-oxygenating them can actually do more harm than good sometimes. But again, just remember, in those elderly patients, not even end-stage COPD patients, but in our elderly patients, if you choose to intubate them, there's a chance they aren't coming off the tube. Their bodies just can't compensate. The bodies can't fight the infection that could potentially develop, which kind of brings us to our next subject, which is pulmonary infections, which are generally caused by bacteria. If we're intubating somebody, it's generally not in the cleanest space. We're not in the OR intubating them. I mean, in paramedic school you are, but outside of that, you're generally not. Viruses, any sort of fungus, any sort of organism really that's foreign to the body can cause an infection. And our concern about the infections is swelling of the airway, right? Swelling causes narrowing. It causes increase in mucus production. So we're going to see those patients that might not have a total lung capacity due to mucus buildup. It also produces pus. And a problem with pus is that, again, it's a very thick substance, very much like mucus, and it doesn't allow our alveoli to open and close. So we get that exchange of carbon dioxide and oxygen. People at risk for developing pneumonia, which is very much a pulmonary infection, elderly population. That's why our concern, with intubating them, or they'll develop it based off of being intubated because they can't compensate. People with chronic illnesses with a weak immune system, chronic smokers that have lung damage as it is, patients that have trouble ventilating efficiently due to maybe a poor lung capacity or a prior injury, excessive secretions. If those are left in place for a significant period of time, that'll turn into an infection. And those that potentially have conditions that weakens their immune system. My mom is a perfect example. My mom has immune system problems, and her biggest fear is like developing pneumonia. So like COVID terrified her the whole time, just because her body probably wouldn't be able to compensate and fight off the infection. Most of the time with an infection, it's not generally something that just happens. Your symptoms don't just come on and you have a massive infection right then. It can come on abruptly, but generally it's a progressive lengthening up until you get sick. Most of the time people aren't even thinking pneumonia, to be honest. They'll be coughing a little bit, they'll think it's just a common cold. When you start to notice or hear them say something about having chest pain when they're coughing, or associated with a fever, and coughing up some sort of mucus, you should start leaning towards pneumonia at that point. And a big problem with patients that we even saw during early on in COVID wasn't necessarily that they were dying of COVID itself, it's that they were developing pneumonia. And what we were seeing was a lot of the patients that were intubated were dying. A lot of patients that were on vents were dying because they had a weakened immune system from COVID. Pneumonia came in due to the infection, and that's what ended up taking them out. Was pneumonia on top of what was going on. Like I said, it can start abruptly, but generally it's pretty gradual. Patients that have pneumonia look sick, and they've probably been sick for a period of time. If they're calling 911 because they think they have pneumonia, they're not doing it in the first couple of days. This is taken a little bit of time for them to get to this point. You might hear the crackles, that fluid in the lung. You might hear mucus. You might feel that rattling of their chest, to be honest. You might listen to breath sounds and hear nothing because their lungs are so full of junk. Pneumonia is going to take up the bases of the lungs first and kind of work its way up. Now, just like any other infection, patients are going to be dehydrated. You get a common cold, you get any sort of sickness, those patients are potentially going to be dehydrated. So listening to lung sounds, giving them fluid as indicated, making sure that they're stable. If they are dehydrated, checking mucous membranes, looking at their tongue, looking at their mouth, looking at their lips, seeing if they could benefit from a little bit of fluid. What these patients really need is antibiotics, high strength antibiotics. Maybe they might benefit from a bronchodilator if you think that their lung passages need opened up a little bit. Now, if it's an upper airway infection to where we're concerned about airway swelling or airway compromise, then that's the point that we need to look at aggressive airway management. By that, we mean if we need to intubate this patient, because if left untreated, we could see an airway that is essentially swollen shut, and we've now lost the ability to get an airway. And then we have to look at an alternative such as, a cricothyrotomy if needed. Atelectasis, again, collapsing of the alveoli due to fluid, pus. Remember I said it was like a thick mucousy substance almost. Smoke or toxic damage, such as chemicals. Ammonia is a big one. Bleach is a big one. People that work in facilities that have fumes, people that are around painting all the time without the proper PPE on. Those are things that can damage our alveoli and make it so that we don't have an exchange of carbon dioxide and oxygen. And alveoli do die off every now and then. That's fine. Everything dies off in our body and is replaced at some point. Skin, parts of our organs regenerate due to, they can heal, whatever it might be. We have cells that are constantly replacing each other, is what I'm getting at. It's just a cycle of life. Now, if they don't regenerate, they don't come back, we don't replace those alveoli, over time, that leads to a dead lung. That leads to a lung that's unusable. Another concern is cancer. Lung cancer is one of the most common forms of cancer that we will see, unfortunately. And a lot of times risk factors come with employment, what the person did. You're seeing a lot of ex-military members that were developing lung cancer. Those work in the fire service are developing different types of cancer as well. People that worked in, tire factories like Bridgestone, Firestone, back before maybe they had to have proper PPE on. These are occupational hazards that where somebody could develop cancer. A pretty good indicator. I wouldn't say that if somebody's coughing up blood, I automatically think cancer, but it is something to think of. One of my grandfathers passed away of cancer, and he was so stubborn that he just didn't want to go to the doctor. He didn't want to go to the hospital, get checked out, because he was afraid of what the doctor would say. And by the time he did go, he was so deathly ill, and was just like coughing and vomiting up blood, that he had like months to live, just because he wouldn't go get checked out and see what was going on. The problem with cancer is it doesn't just stay in one location. It'll generally travel throughout the whole body. Now, cancer in conjunction with COPD, if maybe this is a lifelong smoker, it's worsening the conditions of the person. It's making it so they really aren't going to be able to breathe, to be honest. If somebody's coughing up blood, again, I'm thinking TB. Cancer is usually at the back of my mind. And I'm thinking potential for esophageal varices as well. So there's a couple different things that coughing of blood isn't always indicative of cancer, but what they're saying is it's a common first sign. Now, if cancer gets into our lymph nodes, then it's now in our lymph system. Problem with that is it's going to travel throughout the body. So radiation, chemotherapy will generally be the treatment of choice, but this comes with a cost as well, as it'll cause a suppressed immune system. It'll cause pulmonary function that really isn't up to par with a normal healthy adult, which is normal of radiation and chemotherapy. The problem is these people already have a weakened immune system. If they develop any sort of illness on top of their suppressed immune system, it's usually pretty detrimental for them at that point. There's not a whole lot we're going to do for patients that are either in end stage cancer or have cancer as a chief complaint. A lot of times our treatment can be psychosocial, talking to them, psychological. Maybe they're on pain medication and there's a potential for an overdose on pain meds. So don't ever rule that out, and considering Narcan at that point. Toxic gases I mentioned, like chlorine, bleach, ammonia, really anything that is irritating to the airway itself. Carbon monoxide is technically a toxin, any sort of carcinogen. A concern with people, think of around wintertime, people that with wood burning stoves in their home, or people that are using some sort of stove, is always the potential for carbon monoxide poisoning, or even people that have been exposed to a fire, a house fire, or whatever, vehicle fire, whatever it might be. The concern is always the chemicals and what was burning inside there, in addition to the burn injuries themselves. Burns can also create pulmonary edema, because that infection, or not infection, the swelling, the injury itself will cause like a leakage of pus, a leakage of fluid that we can hear in the lungs, and that's going to really fill up that alveolar space to where those alveoli can't open and close like it normally should. I feel like I've hit pulmonary edema way too much. Acute respiratory distress syndrome. We generally can't diagnose this in the field. And what it is it's shock, people going into a certain form of shock due to impaired lung function. This could be due to not just the things listed here, but even like barotrauma from different altitudes. It could be due to a hypoxic event potentially. It's generally worsened when there's a direct damage to the lungs. With acute respiratory distress syndrome, it's that the alveoli are essentially drying up. They're becoming hard and stiff, and they're really difficult. They're really slow to exchange carbon dioxide and oxygen. What that means for us is that those patients are also very difficult to ventilate. What you'll notice with a lot of these, treatment is supportive. We're providing oxygen, we're providing the medications we can, we're assisting ventilations if needed, and if CPAP, maybe intubation. A lot of the treatment is very much the same, but it's identifying what's potentially wrong with our patients. Pneumos, spontaneous versus tension. Tension is caused by trauma, spontaneous is not. Spontaneous can be caused by weak spots or blebs between the linings of their lungs. What happens is that they get a good cough, or they have some sort of physical activity, they overexert themselves, and they have a collapsed lung. It's not the same as a tension pneumo. It's not putting a massive amount of pressure on their great vessels or their trachea. It's just that lung is not functioning at this point. Generally, those patients are going to end up with chest tubes in the hospital to just make sure there's not any drainage and allow the air to escape at that point. Now, a pneumo is your injury from the outside. We create an opening. A spontaneous one is more of a injury between the outer lining of the lung and inner lining. So the outer lining can usually be intact, but the inner lining has had a collapse, and that's what's causing the pressure. So the outer lining of the lung is still there, as like we saw in that x-ray, we still had that dead space, that black spot, but the rest of the lung had shifted in. It was just unusable at that point. Treatment for them, most of the time, is not going to require any intervention. The times I've seen people with spontaneous pneumo, honestly, I would have never guessed they had one. They wouldn't have guessed that. They just thought they had, or were developing some sort of sickness. They had a cough. They had some sort of sharp chest pain. Might have been like, a pulmonary infection or something like that. And I was actually kind of shocked to find out that they did have a pneumo. It's only happened a couple times. I think one of them, honestly, was in paramedic school that I can remember. And another one was probably a couple years after that I had followed up on. Maybe there's been more than that, but again, I would have never guessed that. A pleural effusion, again, when we lose the fluid in between the linings of the lung linings then rub together. Well, over time, they can develop like a blister. And what happens is that blister becomes painful for patients. So these are the patients that especially want a tripod. They want to sit forward because their lungs are going to swing forward. It's going to make it so that there's not any pain because the linings of the lung aren't rubbing together at that point. You might hear a pleural rub as far as assessment goes. Again, very much like a broken rib cage, they're going to want to breathe as minimally as possible because any extreme exhalation or inspiration is going to cause some pain for them, to be honest. So care might include pain medication for these patients, to be honest. The last section of this is PEs, a pulmonary embolism. So a clot that has been lodged in one of the pulmonary arteries. Generally, this clot is traveling up from somewhere else inside the body. Patients that have DVTs, deep vein thrombi or deep vein thrombosis are predisposed to developing a PE. Females on birth control are more prone to developing a PE. People who drive for an extended period of time, maybe those who are bedridden, recent surgeries. These are all reasons that somebody could develop an embolism. Our fear is that again, that embolism travels from wherever it was at up until it gets lodged in the pulmonary artery, cutting off blood supply to the lung, therefore making it so the lung doesn't exchange carbon dioxide and oxygen. These patients can have normal pulse ox. They can have normal breath sounds. They're just not having the act of respiration. They're not having an exchange of carbon dioxide and oxygen. It's not a blockage of the airway. You can bag them perfectly fine, but their body doesn't have the ability to exchange carbon dioxide and oxygen at that point. The video I'm going to show you guys is what's called a saddle embolus that had traveled up from a deep vein thrombosis. It's actually kind of a cool video, and you'll get to see how the saddle embolus took the shape of one of the arteries in the lower leg. Now, if they catch it soon enough, or if it's like a semi-blockage, they might not do surgery, and they might put give you some sort of clot busting drug such as TPA to break up the clot. Or if you have DVTs or something like that, they might put the patient on blood thinners as well if there's a potential risk that the patient might develop blood clots or they're concerned about it. A saddle embolus, the fear with a saddle embolus is it sits right over the bridge of two arteries. And in the video, you'll see it perfectly. The problem is it is the most fatal embolus that can occur with somebody. Just because it's not blocking just one pulmonary artery, it's blocking both of them. So now instead of 50% reduced, we have 100% reduction of the ability to exchange carbon dioxide and oxygen. All right, I'm going to play this video real quick, and then I'll answer any questions for you guys. Whoa. All right, can you guys see this YouTube pulled up on here?
Yep.
Yes.
In this video, we're presenting a case of a massive pulmonary embolism and then a pulmonary embolectomy. The patient is a 30-year-old female who presented to our emergency room with back pain and shortness of breath. She had risk factors, which included taking birth control pills and smoking a half a pack of cigarettes a day. A chest x-ray was obtained, and this was a relatively normal chest x-ray. Therefore, an ultrasound was ordered.
Rudy, I think when you muted, we might have lost sound.
All right, there you go.
Following the echocardiogram, the patient became unresponsive and hypotensive. A stat CT scan was performed, and you can see here at the saddle point on the pulmonary artery, there is a large pulmonary embolism.
This is the stuff that I want you to
This
see.
process
It's
is
coming right
taken
after this.
emergently to the operating room for a emergent pulmonary embolectomy and retrograde pulmonary perfusion. Here's the patient's heart prior to going on bypass, and you can see the right ventricle is distended and not functioning well because of the pulmonary embolism distally. In the right superior pulmonary vein, a arterial cannula was placed in preparation for retrograde pulmonary perfusion. Stop, and the pulmonary artery was open. Here's the main pulmonary artery, and you can see a very large thrombus obstructing the main pulmonary artery at the branch point between the left and right main pulmonary artery. You can see how utterly large this pulmonary embolism is as we remove it from the pulmonary artery. It measured over 11 inches in size. On further inspection, there was even more embolic material. This is all thrombus that originated from the patient's lower extremities or her legs. She had a deep venous thrombosis, which then moved into her heart and caused this pulmonary embolism. You can see why DVTs can be life-threatening when they become pulmonary emboli. You can also.
So that's what I wanted. That right there, when it sits over where your arteries bifurcate, that's why it's called a saddle embolus. Is it just sits right over both of them essentially, and it's again the most fatal type of PE that you'll potentially see. This lady's damn lucky that they were able to find it, and how she was still functioning with having that big of a PE is beyond me.
Also see the clot extends into the small branch points in the pulmonary artery. This was removed as well. Here is the specimen that was removed from the patient's pulmonary artery. You can see it's almost a perfect cast of the patient's common femoral vein and iliac vein. And you can see this embolized or transferred from the leg to the heart and obstructed the pulmonary artery. Here we're performing a retrograde pulmonary perfusion to ensure that all the small clot and debris was removed. The patient was taken off a cardiopulmonary bypass. The heart was functioning well. She was extubated on postoperative day 3 and discharged home and made a full recovery. This ends the video.
That when I came across that video, I think I first saw it on Facebook or something like that. I was honestly shocked at what had transpired there, to be honest, because to read about it is one thing, but when you can put what you learned into a video, and that's why I keep on saying YouTube is not a bad resource to turn to, because you can find stuff like that. Absolutely, I would, because it's going to put an image into your mind that might ingrain a little bit better than just words. You might remember that being a saddle embolus as opposed to just a PowerPoint. So when I say if you don't understand something, try looking up on YouTube. I'm not trying to be funny or anything like that, but for some people, it honestly is a great resource. What questions can I answer for you guys in regards to this lecture?
I've got a couple, Rudy.
Okay, yeah, go ahead.
For hypoxic drives, I don't remember if we touched it or not. Will you see any difference on an end tidal reading?
So good question. And yes, you will. So pulse ox, remember, takes a little bit of time before we can start to see a change. And even though our pulse ox can show normal on these patients, they're really starving for oxygen, because pulse ox is measuring the amount of oxygen in the bloodstream, right? Now, it's going to take a little bit of time before our body realizes that the lungs aren't oxygenating it. That blood's going to still keep going around and around. So your pulse ox is going to slowly start to change. As to our end tidal is measuring expired air. So that's going to change almost immediately, and you'll start to see your end tidal continue to go up. And when we get into cardiology, there are some things that you can look for on a 12 lead that could indicate the patient's having a PE, but nothing definitive. That
Gotcha.
makes sense.
Yeah. And then the other one I had is for the acute respiratory distress syndrome. You said that those are pretty hard to determine in the field.
Yeah.
Will they have any sort of differing lung sounds?
Not necessarily. They can have a combination of different lung sounds. So ARDS is really just a combination, a culmination of things that have all come together for the perfect storm. So it's, stiffening of the alveoli, so they're not really able to open and close like normal. The stiffening could be caused by mucus, so you could hear rhonchi or the rattling. The stiffening probably isn't going to be caused by fluid, so you're generally not going to be hearing crackles, but it could be drying out as well. So you might hear clear lung sounds, to be honest. You could hear clear, you could hear rhonchi. There's no definitive sound that's going to be, heard one versus the other. It's unfortunate. That's why they say it's almost difficult for us, or almost impossible for us to say what it is in the field. It's a combination of a bunch of things that have come together, and it really takes them at the hospital to perform different tests to say that somebody's in ARDS.
Gotcha. Okay. Thank you.
Any other questions?
Rudy, when we were talking about asthma,
Yeah.
you talked about bronchospasm and bronchial edema.
Uh-huh.
Both showed wheezing
Yep.
as symptoms, but they had different managements. So for bronchospasm, we would do the bronchodilator, probably nebulized. And
Yep.
for the bronchial edema, you're looking at a corticosteroid. The bronchial edema said that the bronchodilators don't work. So with the same symptoms, is there a way that we can diagnose between the two in the field, or do you just start with you're hearing wheezing, so you do your neb, and then when that doesn't work, you move on to bronchial edema, or thinking about bronchial edema and steroids, which we wouldn't typically do in the field anyway, right?
No, actually, you would.
We do.
Yep. And that's honestly most respiratory protocols. Like I'll tell you mine right off the bat. If I hear wheezes, I give a duoneb. In addition to the duoneb, I'm giving 125 of solumedrol, which is a steroid.
Okay.
I'm giving fluid if they need it, and then I'm following up with neb treatments. If the breathing's so severe, I might give epi just to open up the airway. So really, if you think about it, you're giving the neb treatment that might treat the bronchospasms, and you're also giving the solumedrol that might, it's not going to treat the edema in front of us. It's going to treat it more long-term once they're at the hospital, but you're giving both the treatments at the same time, essentially.
Okay. So you're not really trying to diagnose between the two. You're
No.
just treating the wheezing.
Exactly, exactly. Yep.
Okay.
And again, look at that waveform, capnography, because once you see those shark fins, that's a really good indicator of bronchospasms. Even if you don't hear wheezing, if you see that waveform, that's justifiable to say, okay, I'm having some sort of lower airway disorder or some sort of lower airway issue just based off that shark fin waveform. I'm stuttering over here. That alone will tell you that they're having some sort of muscle contraction in the lower airway that is really indicative of asthma or some sort of other bronchospasm, maybe due to a chemical or irritant or something like that. And that's why diving into their history might be a little bit more important too. You know, where do they work at? What's changed? Have they come in contact with anything? Do they have a history of asthma? And then trying to, you know, base your treatment around that, if that makes sense.
Thanks.
Yep. Any more questions about this content? All right, if not, I will answer. Let me stop the recording here.